I would like to start with the clerk calling the roll for the purpose of a quorum.
Senator Miller.
Here.
Senator Valverde.
Here.
Senator Lawson.
Here.
Senator Bell.
Here.
Senator Calkin.
For a Thursday.
Senator Demario.
Here.
Senator Golden.
Here.
Here.
Senator Paolino.
Here. Here.
Thank you. Before we get started, I do want to send my wishes, and I know the wishes of everybody on this committee, and that one of our committee members has serious health issues, and we all wish her a recovery as soon as possible. I know that everybody feels the same way, but I did want to mention that before we get underway. I think Senator Golden, was she called for the purpose of a quorum? Yeah.
Yes.
Okay. Our first business is we have several bills scheduled for consideration, so I'd like to go through those before we hear from senators on who are present to speak on their bills. The first bill is Senate Bill number 305, an act relating to health and safety, alcoholism. We had a hearing on this bill last week, I believe it was, or 2 weeks ago, because last week was our break. And I explained that it requests revisions to the current statute around emergency commitment for drug intoxication, and the title itself represents why we are requesting the revision, and this is pretty repetitive throughout the current statute, is that they use words like drug intoxication instead of the language that is current, as the language is over 40 years old without any revision. Are there any questions, or do we have a motion for passage? By Senator Bell, seconded by Senator Valverde. Can the clerk take the roll on this?
Senator Miller.
Yes.
Senator Valverde.
Yes.
Senator Lawson. Senator Bell.
Yes.
Senator Calkin. Senator Demario.
Yes.
Senator Golden.
Yes.
Senator Paolino.
Yes.
Thank you. The next bill for consideration would be Senator Quesada's 484, an act relating to human services, perinatal doula services. Been discussed thoroughly for a few years on the Senate side, and we look forward to consideration both on the Senate floor and on the House on this bill. Is there a motion for passage?
So moved.
Passage.
Senator Bell moves passage, seconded by Senator Valverde. The clerk?
Senator Miller.
Yes.
Senator Valverde.
Yes.
Senator Lawson.
Yes.
Senator Bell.
Yes.
Senator Calkin. Senator Demario.
Yes.
Senator Golden. Senator Golden. Senator Paolino.
Yes.
We have 6 votes, so that bill will be put forward to the floor of the Senate. The next bill we have is Senator Coyne's bill number 651, Breast Cancer Act would allow individuals to be sent breast cancer screening results by mail or otherwise. Motion for passage by Senator Lawson, seconded by Senator Valverde. The clerk?
Senator Miller,
Yes.
Senator Valverde,
Yes.
Senator Lawson,
Yes.
Senator Bell,
Yes.
Senator Calkin, Senator Demario,
Yes.
Senator Golden,
Yes.
Senator Paolino,
Yes.
Thank you. Does Senator Golden wish to be recorded on 651 for passage?
Yes, thank you.
Yeah. The next bill we have is Senator Goodwin's 713, which takes away the sunset on the Office of Medical Examiner's review of team review of drug-related overdose deaths. Motion for passage?
Mr. Chairman, I have a quick question on this
Sure.
legislation, if I may.
Yeah.
Was this a legislation, there was some discussion, and I think it was this bill, but I could be wrong, that there were some comments by the ACLU that we were going to have the committee attorney look into and consider whether there be a modification. Was this that bill? And if so, do we look into that and determine a reason to not make those changes?
Let me discuss that. I don't have that. No. Yeah, I don't think it's this. It's just a sunset date on this bill.
I thought that they had some concern about the composition of the committee. We were going to look into it. I could well be wrong. Let me go research this and go back and see if that was the case, and if so, maybe we can address that on the floor if it's necessary to address.
We'd be happy to review that before it was voted on to see if it's amendment to add or take away a member.
Okay. I mean, I have no objection to us moving passage now if it's necessary.
Yeah.
We could make a change on the floor.
We'll check that before.
I'm not trying to derail the passage vote. I just want to make sure that
we'll check that. We'll check that before it goes to the floor so we could propose an amendment if that's true.
All right. Thank you so much.
Yep. Is there a motion?
With that, I'll move passage.
Passage is moved by Senator Bell, seconded by Senator Valverde. Can the clerk take a vote?
Senator Miller,
Yes.
Senator Valverde,
Yes.
Senator Lawson,
Yes.
Senator Bell,
Yes.
Senator Calkin, Senator Demario,
Yes.
Senator Golden,
Yes.
Senator Paolino,
Yes.
Thank you. And we'll look into the issue brought up by Senator Bell. So now I would like to have, we have a few senators with us, and I believe also Senator DePalma might come in at some point to introduce his legislation. I don't believe Senator Oyer, she indicated she wasn't able to attend as she's doing other business. So we can go to Senator Gallo on Senate Bill 302.
Thank you, Chair, and thank you for committee members today listening to my bill. I think while we were passing all these bills, we might as well just put this right in that whole click there and get it in there for the passage. All kidding aside, this is a bill that we've heard for the last few years. And what it does is it makes it so that patients can be exempt from the step therapy protocols when inappropriate. And that patients have access to a fair, transparent, and independent process for requesting an exemption to the step therapy protocols when the patient's physician deems appropriate. So, and I don't know for the new members that haven't listened to all of this, but a lot of times if somebody has lupus or they have cancer or they have something serious, that's debilitating, and they're not able to function, they can't work, they can't care for their children, they can't do anything. And the way it's set up with step protocols, you have to try one medication before you can go on to the next, and then the next, and the next. So you could be sick for years until you get to the medication that your doctor feels is best for you and could not necessarily cure you, but you could be able to function within your life and have your life back, but you don't have access to it because they want you to go through all of these steps. So this would eliminate all the steps, and it would let your professional make that judgment. And I'm available if anybody has any questions, and that's it. Thank you.
Senator Golden, do you have a question? No. Okay. Any questions from the committee? I am going to, because we do have a few senators who wish to introduce, I'm going to go to the calls after, so those senators can get back to their committee or the other work they have, and then we'll take some calls, and I believe there are a few calls on this bill, but we'll take all of those calls later. So, and we'll make motions after the calls. So.
Thank you.
Yep. Thank you for getting on the screen with us.
Thank you for having me. I enjoyed this.
So the next bill we have that a senator is present to introduce is Senator Archambault's number 304, unanticipated out-of-network bills or health care services. Senator Archambault.
Thank you, Mr. Chairman, members of the committee. Good evening. For those of you who haven't been here in past years, we have tried to get this bill passed on at least two occasions. The Senate actually passed it, the House passed it, and then passed it out of committee, but then a lobbyist came at the 11th hour for the insurance company and whispered in the ear of a big fish on the House side, and the bill died. And I start with saying that because, you know, very often when we put our bills before the committees, we're all passionate about them, and we like to say, this is a good bill. But you tell me if you think this is a good bill. You go in for a procedure and we all have Blue Cross as senators. You go in for a colonoscopy, got Blue Cross. You sign all your waivers. You don't know that the nurse anesthetist or the anesthesiologist doesn't take Blue Cross. They take United Health. You come out of the procedure, you're fine. You don't have any, couple of polyps, they were benign, we removed them. By the way, you've got a $3,000 bill because that provider was out of network. You said, oh, wait a minute, I didn't consent to that. That's the way the law currently is now. And you, as the consumer, have to fight it out with the insurance company to either reduce that bill or assuage assuage is the wrong term, reduce that bill or come up with some other alternative remedy short of paying the $3,000. So, to Senator Miller's credit, he was unbelievable on this. I think 4 years ago, we actually had 14 sub-hearings on this bill. I went across to the House side, downstairs to a part of the State House I'd never been in. We had all the doctors' lobbyists on one side, the health insurance lobbyists on the other side. Senator Golden was involved as well. And there was a tremendous effort put towards crafting this bill. The Senate President had assigned someone who was on the staff before to work on this bill. And in the end, we came up with a remedy that dealt with, I say a remedy because the sticking point was when the doctors and the health insurance companies couldn't agree on what the fee should be based on the regulatory rate, the remedy was sort of a hybrid arbitration, one that sought to use law that existed in Connecticut and law that existed in New York. And we all thought it was sound. And at the table, back then, all parties said, well, we're not necessarily happy, but we can live with it, right? And that, to me, that's the sign that you got a pretty good piece of legislation, because the consumer is going to be taken out of the picture. They're not in the fight anymore. Let the doctors, who are small businesses, and the insurance companies sort of fight it out. Well, as I said, I started with, at the 11th hour after it passed, the insurance companies went over and lobbied on the House side and killed the bill. That's true. That's absolutely true.
And you don't think that's ever happened to any of us?
And so, look, that's what happens up here, right? In the dance of legislation, we all know that. We have these lobbyists that they, Senator Miller, that levity was appreciated. This is what we're up against. But I say that to you, my brothers and sisters here in the Senate, because this truly is a consumer bill. It's a good bill. And I remember one person testified a few years ago about how they wound up having like a $40,000 or $50,000 bill. They lost their house. That shouldn't happen. It shouldn't happen. The doctors should have been paid something for the services. The insurance company should have compromised. It shouldn't be that the consumer loses the house. So, anyways, the little squib on it says the act would provide a method for reimbursement to out-of-network professionals who provide unanticipated out-of-network care, and would provide guidelines for what payment out-of-network professionals may seek or accept from a patient for unanticipated out-of-network care. And I'll just end with this. There was a statement made in past years by the insurance industry saying, well, there aren't a lot of these cases. There's only a handful. Well, the last I recall, by loose analogy, our Bill of Rights protects the minority against the oppression from the majority, right? That's how we all feel. So even if there's just a couple of people, what about that one person who would have lost their house, and I think did lose their house, from an out-of-network bill? It shouldn't happen. This bill fixes it. And it got some really good press in the past. I have no ego here. I don't care if my name was attached to it. I just want the bill to pass to help consumers. And I'm open to any questions you may have with respect to the legislation. Thank you for indulging me, Mr. Chairman.
So, Senator Archambault, I want to bring up a couple of issues around it. I believe, but you can correct me, that this is the same language from the previous time it was brought before us.
Yes.
Yeah.
Yeah. Yes,
so
it is, sir.
That gives us a couple of issues on it that I wanted to review before we have it back to be considered by the committee, is that there are some definitions that have been highlighted by staff that might need to be worked on. And the other thing on this bill is that it might need to be revised slightly based on federal action that took place last year. And so what is needed, what is redundant, and that's all just how federal action that took place last year implicates the bill. And so those two things would be, I think, important to have the bill before us after that review, so it is effective as intended.
Thank you, Mr. Chairman. Thank you for that. And I have no one better to do any of that conducting than you, as if you've got free time. But I appreciate that. Any of those concerns, I'll meet with Ledge Council and whatever needs to iron it out. Thanks for pointing that out.
Yeah. Any other questions for Senator Bell? Also has a question for you.
So I think this is an excellent piece of legislation. I do hope we pass it this year and we can get it through the House. My question is about these committee analyses. Often in this committee, we've had discussions of analyses performed by the committee staff. But I was wondering if it would be possible to share those analyses with the committee, just so that we can see the specifics at issue here. If that's possible. If it's not possible in a timely manner before we vote, I totally understand. But in the future, when we make decisions based off analyses, I would like to be able to see those analyses, because they do and should, I think, inform how we vote.
Yeah, I agree with you, and we'll get first for the sponsor to look at, and then for the committee to look at also.
Mr. Chairman, I often give Senator Bell an affectionate hard time telling him I think he knows my bills better than I know them. And I mean that sincerely. If you want to peruse through that and you come up with something that'll make it better, Senator Bell, I'm all for it. I appreciate your intellect and the fact that you dedicate the time and that you care. Thank you.
Any other questions? Thank you. I believe Senator DePalma wishes to comment. Oh, let's go to Senator Demario first because she's here on Senate Bill 485.
Sure. Thank you very much, Mr. Chairman.
Yeah.
So this bill, which would require insurance companies to cover backup batteries for at-home medical devices such as CPAP machines. This really came from a discussion that Representative Potter had with a constituent, and then, in looking at policies that I thought, or legislation that I thought would be helpful in terms of helping connect people to be able to have better coverage for the things that are necessary, I wanted to look at this further. And so basically the issue is that when we lose power, and as we all know in various parts of the state, that happens with a lot of frequency, these machines are not operable. And so the point was made by this constituent that, when she tried to pursue insurance coverage for a backup battery, which costs around $200, she was told that was not covered and that was not a necessity. And so I think it just kind of gets at a larger conversation of, if we have, if according to the current rules that are in place and the current procedures that are in place say that a certain at-home medical device is necessary for a patient, then we should ensure that is able to be used in all circumstances. And if there is that possibility of being able to have a backup battery that would make it operable in case of an emergency, then I think we should try to find a way to make sure that is covered. So I do know that we received some written testimony from the Office of the Health Insurance Commissioner pointing out that, because this could potentially have a fiscal impact, that this particular way might not be the best way to connect those two dots, but I do think that it's part of a larger conversation, again, about making sure that if we're saying that this is a medically necessary device, then that's something that we can make sure that patients are able to use regardless of the circumstances. I'd be happy to take any questions.
On kind of the other side of the issue from the Health Insurance Commissioner on the potential rate implications, the other consideration might be that we would want to look at a standard of battery that would be covered, because you don't want them to only cover a battery of a low standard and a less expense. You want it to be as quality as the manufacturer recommends, as an example. So people aren't told that they will only be covered for a low quality battery. And so that might be something to be considered.
Absolutely.
Yep.
Yeah. Thank you.
Any other questions? Thank you. Senator Lawson, you have, I don't believe Senator De La Cruz is here on the health insurance, her bill number 644. So I'll skip over to you on Senate Bill 646.
Sure, thanks, Mr. Chairman, members of the committee. This act would require coverage for the treatment of pediatric autoimmune neuropsychotic disorders associated with streptococcal infections, also known as PANDAS, and PANS, which is the pediatric acute onset of neuropsychotic syndrome, and not limited to the use of intravenous immunoglobulin. So PANDAS and PANS is when an infectious trigger, often a strep infection, environmental factors or other things trigger and create a misdirected immune response that results in the inflammation of a child's brain. So it leads to sudden and acute onset of symptoms, things like OCD, severe restrictive anxiety, tics, in addition, personality changes, could be decline in math and handwriting skills, sensory sensitivities, and more. So when a child is struggling with these symptoms, the whole family struggles. It impacts all of their quality of life. In many instances, children suffer for years and they're unable to live a happy life. And there's a couple of pieces of written testimony that were in the packet that do unfortunately describe what actually happens to a child affected by this. And the estimates are that it's 1 in 200 children are impacted by PANDAS or PANS. And another problem here, it's been a challenging for medical doctors and mental health professionals to diagnose, because sometimes it's caused by an infection that hits the immune system, mistakenly attacking the brain. And it can often mimic other illnesses. And there are also issues regarding medical coding. And it looks like that might be being in the process of being addressed by January 22, where PANDAS would be included. So far, legislation similar to this has passed in 8 of the states, and this bill would provide an opportunity for children suffering and give them coverage and relief desperately needed for these children and these families. And I'd also like to add, I'd really like to thank Senator Demario for her support and input and as a resource, and I hope she's going to help me answer any questions along the way. And I'd be happy to take them with her help. Thanks.
Any questions for Senator Lawson on Senate Bill 646 on the committee at this time? There might be questions if we have calls on that bill later. So,
Thank you, Jim.
before I'm going to go out of order because Senator DePalma has joined us to do an explanation on his bill 793. Senator DePalma.
Thank you, Mr. Chairman. Thank you, members of the committee. Yes, I just left finance. We go back to finance when we finish this here. But so thank you for allowing me to brief the legislation we have before us. It's pretty straightforward. Mr. Chairman, you and I have talked about this over time, and I've talked with others as well. There are many places where the administration doesn't follow the law. This is one of those. So what this seeks to do is ensure that we do follow the law, and when we don't, there's something to take that into account. So I call your attention to page 2 of the bill, lines 2 and 3, item III, where it says a rearray of costs for all facilities every 3 years beginning October 2015 that may or may not result in automatic per diem revisions. And this relates to what's on the prior page, which I'm not going to go through in detail, that basically says the executive office of HHS shall review the current methodology for providing Medicaid payments to nursing facilities, et cetera, et cetera. So it basically says every 3 years you're required to do this. This is what Rhode Island general law stipulates. It's not happening. So fast forward to the change that's being requested by the for the committee is basically the last 2 paragraphs. And it basically says, in the event the rearray is not done, as described, there would be an automatic per diem increase for 3%, effective on the date the rearray was scheduled. And it would be respective of and of in addition to any automatic inflation index adjuster. And if you look at it, folks know on this committee, I suspect CMS has that out there for 40 years. If you want to go look at what the CMS inflator is, you can go find the 40 years that they've done. I think we're at the tail end of the 40. I can't say exactly where we are in that, having looked at it a few times, but that's what it aligns to. And then I ask you to look at paragraph D. Because one of the things we've talked about this, and I have other legislation in labor, and it's been a big issue, that when minimum wage goes up, we need to address other things that might be aligned or tied to that. Well, not necessarily tied to it, but there should be some type of indirect linkage. That's what this seeks to do in lines 24 through lines 31, is that should there be an increase in minimum wage, not done here, that at the same time minimum wage goes up, you'd also have a corresponding percentage addressed for this as well. So, in short, why is this needed? The state's not been doing what they're supposed to. How are we addressing it? We're putting in place an automatic mechanism that would allow this to occur. Part A, Part B, in order to address what we're seeing and have been seeing as we expect with minimum wage going up over time, and based on what we just did with minimum wage, I think the cat says yes. What we've seen with minimum wage over the next N number of years, we expect it'll go through and the governor will sign. We need to have this here as well. So thank you, Mr. Chairman and members of the committee.
Any questions for Senator DePalma from the committee? Senator Bell?
Thank you so much, Mr. Chairman and Senator DePalma. I share your concerns about the statute not being followed with regards to nursing home Medicaid reimbursement rates, which are woefully low and create a number of severe public policy problems because of their low rate levels. My question is how this would affect the nursing home's ability to recover some of these funds through civil suits.
So I'm an engineer, Senator. I'm not a lawyer. I don't have I'd like to answer it, but I can't. I wouldn't know how to give you an answer. So.
Okay, I just want to make sure that by creating a remedy, we're not weakening the case for a civil suit to recover funding that is not there. And if we create an additional remedy, I want to make sure that doesn't weaken a case for a civil lawsuit.
Great point. Yeah, I just can't answer your question.
Okay, that's fair.
Any other questions for Senator DePalma? Thank you for joining us.
Chairman, thank you. I'm going to go back to finance. Thank you very much.
Okay.
Thank you, committee.
Yep. So if we go back to the order of the posting and who's present to testify on their legislation, Senator Demario, we can go back to you for Senate Bill 647, health insurance oversight.
Thank you, Mr. Chairman. I also have on the agenda Senate Bill 643. I don't know if you want me to go back to that one first or if you want me to go right to 647.
However you want to go forward.
Okay, I'll go in numerical order. So Senate Bill 643 is really situated within that larger context that we were talking about a few weeks ago in this committee regarding trying to protect particularly our behavioral and mental health care provider workforce. So the situation with this bill is that insurance companies currently in Rhode Island have the ability to recoup payments, or the kind of common term for that is clawback payments, up to 18 months after a service has been provided. And that's for all types of healthcare providers. And so the change that I'm seeking is to bring this in line with some more of our neighboring states and the cutoff date that they have in, for example, Massachusetts, so to change it from 18 months to 12 months. And so the reason for this and how this is situated in that larger issue of trying to protect our behavioral and mental health care provider workforce is that oftentimes it is the smaller providers and the independent providers of all types that are most affected by things like this. So, you know, when you have a smaller type of practice and, you know, you have this additional administrative burden of needing to, you know, go back and chase after payments from a different insurance company, for example, up to 18 months after a service has been provided, you know, that's a really big burden to have to go through. In addition to that, you know, when you're talking about losing revenue that you thought you had already counted on for being able to meet your obligations and meet the overhead costs of running your business, it has a really big impact. And so, you know, just to maybe answer a couple questions that people might have about this, you know, when a provider is going to provide a service, it is incumbent upon the provider to check to make sure that that client or patient is eligible on the date the service is given. And so these are situations where the provider has done that, whatever mechanism, you know, whether it's a telephone call check or whether it's checking online, you know, that eligibility has been has been verified by the provider, the insurance company has then paid that claim, but then upon review up to 18 months later, they might find that in fact, that person was moving jobs and actually was changing an insurance plan, and therefore there could have been other insurance coverage available, and so they will then claw back that payment. The difficulty is that it is very difficult then for a provider to be able to track down that patient or client if they're no longer connected with them, and then B, recoup that payment from the other insurance company after such a time lapse has passed. And so bringing it from 18 months to 12 months, makes it a little bit easier to maybe go back and do those administrative tasks, and also provides a little bit more predictability for some of our small practitioners. So I'd be happy to take any questions about this that anyone might have.
Any questions from the committee on this? Senator Valverde.
Thank you, Chairman. Senator Demario, how often does something like this happen, that a payment is clawed back? I know that you are a mental health counselor, so you must have experience with this.
Sure. So, the frequency, obviously increases with the volume of services that you provide. But, just, kind of doing an informal poll of some of my colleagues in private practice, this is something that happens, at least 2 to 3 times a year, if not more often. And what we're talking about is, recoupments like for usually multiple service dates at one time. So you're talking about maybe like a $500 to $1,000 clawback that all of a sudden you then need to have reimbursed to the insurance company. And again, that's the equivalent of like a month or 2 of your office rent. Like that's the equivalent of your license renewal fee for a couple of years. So it really does impact the financial viability of independent practitioners who continue to take insurance coverage, because there's really no way to make up that revenue. So there are only so many hours in the day, and it's obviously not ethical to just see clients more frequently than is necessary to try to make more money. And so it just really leaves providers in a bad spot. But yeah, again, the frequency would increase with the volume of patients or clients that one sees, but it happens pretty much to every practitioner, at least a handful of times per year.
Senator Demario, I just had a question. I tried to go over it with counsel, and it might be something we want to review or make explicit in the legislation. We had a commission on reimbursement that we still need to report out for many reasons, including that we need a resolution to extend the date that we can report out from that commission. But one of the things that came up was how many providers were clawed back, and it was brought up several times from the MCOs. And so we want to make sure that this language also applies to reducing that claim period for MCOs too. I'm not sure with the people who helped you draft this legislation whether that came up or not.
Thank you. So this really, this was kind of, again, my sort of first stab at trying to fix this. And so basically all we did was we took the existing statute and just changed it from 18 months to 12 months. So, any additional clawback reduction, measures weren't taken into account with changing this language. So, for example, like in Massachusetts, they also have a provision that, the provider then, if there is a clawback request, has 30 days to be able to try to take corrective action or kind of fight that back basically with the insurance company. And so I think that as you were saying, I think that there are probably other ways to try to address this issue as well. This is simply just changing the time frame.
Our interest would be just making sure it also applies to the insurers who are under contract with Medicaid. Because what we heard in that commission was this was hundreds of thousands of dollars for MCOs on it that was clawed back. And so we wanted to make sure that the bill was effective there as it was elsewhere.
Yeah, that makes sense.
Yeah. Any other questions for Senator Demario? So you can go to the next bill if you wish, so we don't have to keep
Great.
going back to you.
Thank you. So, Chair Miller, obviously this is a bill that you are very familiar with. So this bill, again, is basically looking to decrease administrative burdens on providers and connect people with their needed care faster. The prior authorization process is something that exists now where, you know, and probably in our personal lives or in our families, we've all experienced this issue where a healthcare provider needs to basically make a case in writing, usually, to a patient's insurance provider about why a prescribed treatment medication service is medically necessary or is necessary in their situation. And so that is the system as it exists, and you know, so we'll deal with the reality we have right now, which is that. And what this bill seeks to do is to reduce that administrative burden a little bit, connect people with their care faster by having all insurance companies adopt a uniform practice for that prior authorization. So the situation as it exists now is that different insurance companies use different forms, want different information, and so obviously it takes longer for, you know, the whatever the healthcare provider entity is to be able to make sure they're using the right form, doing the right procedure. And then the other thing that exists within that reality is that people change insurance companies often, and also insurance companies change their policies around prior authorization procedures. And so what happens then is people get caught, you know, the patients get caught in that waiting period because maybe the wrong form was used, because, you know, it was thought that it was the form for one insurance company, but it was the other one, or maybe the information, it doesn't quite sync up between the two different insurance plans. And the result is that there is a longer waiting period because of that high administrative burden between a patient needing some type of treatment or care and being able to get the approval for coverage for that care. And so what we're trying to do is just make sure that all the insurance companies can agree on one uniform set of forms or practices. And I do want to point out with this that, you know, this is a process that occurred a number of years ago with billing claim forms, where now that is a uniform standard that all insurance companies use the same form for billing purposes. And so this is kind of seeking to replicate that type of process, again, you know, with that ultimate goal of reducing the time and effort that it takes administratively for for healthcare providers to be able to go through this process and get their patients what they need faster. I'd be happy to take any questions.
Any questions from the committee on this bill? This bill is a priority of the medical society, not only locally but nationally, this type of legislation. And so one thing we might do is, I know it's taken from previous year language, we might check with medical society to see if there's been any national progress on this, or whether there's still a local initiative or a language change that they recommend on that. Senator Demario?
Yeah, if I can make a comment on that, I'm aware that that is something that is in progress, and I've recently been in touch with a local representative from that organization, you know, around their efforts on this. And I think, you know, it's also just kind of a larger philosophical question of, you know, who is the one to best determine what is appropriate care. And, you know, we have this situation right now where ultimately it is the insurance company that is the gatekeeper. And, you know, there was a lot of written testimony that we received from various insurance companies and related organizations around that idea that, you know, basically they know best about care. And I think that is also just kind of part of a larger conversation about, you know, who really should be in charge of determining best care, a physician and their patient, or health insurance companies. So thank you.
Senator Bell might have a question for you on this bill.
I do, yes. So thank you so much, Chairman, and thank you, Senator Demario, for putting in this important legislation to reform this abusive practice. My question is about the level of discretion given to the Health Insurance Commissioner here. I'm wondering why so much discretion needs to be left in the hands of this one particular regulator, and why we can't legislate what some of those criteria are to ensure that sufficiently strong regulations will be brought forwards. And to be somewhat blunt about it, I'm concerned that the particular administration we have now at OHIC may not impose sufficiently strong regulations.
I think that's I think that issue is in the bill in that it requires the health insurance commissioner. It doesn't give him the discretion to do as defined in the bill. He's required to do it. And so I have confidence.
I'm aware of
that
that.
would be executed by law.
My question is, I'm not suggesting that the health insurance commissioner will violate the law. My question is that exactly what the medical criteria are remains entirely up to OHIC, without even a requirement that it be based off certain standard practices or research or achieve certain goals and principles or things like that. And so it's essentially the entire discretion lies within OHIC, not over whether they execute the law, but over what the criteria are. The only requirement is that they be uniform, not that they meet certain standards and or achieve certain goals or follow certain principles and practices. It gives almost total discretion over exactly what those criteria are going to be to OHIC. So that's my question for Senator Demario. What's the rationale for leaving so much discretion in the hands of OHIC, and would it be possible or to provide some additional clarification on what those criteria should be?
So from my perspective, I think that this bill and also what you're saying are not mutually exclusive. I think, when Chairman Miller was speaking earlier about the Rhode Island Medical Society, and I had referenced that I had recently, and by recently I literally mean in the last 24 hours, have been in touch with them and learned about, some of the process that they had been starting to do to come to an agreement, around not just specifically the prior authorization documentation issue, but also some of those larger medical necessity issues that you were talking about. That is part of a kind of a broader effort that is also being looked at. So I think that, from my perspective, this is like a next step kind of bill to be able to, as I said, reduce the administrative overhead and to connect people with their care faster. But then, like, the next step after that is also, looking at, because right now there are those diverse sets of medical necessity criteria between insurance companies. So there, it's not like there is even that standardization. So, I think that what you're saying and this bill are not mutually exclusive, and I agree with your larger point that needs to be a bigger, a next step or an additional step that needs to happen. And, I know that the Rhode Island Medical Society is working on that as well.
Thank you so much, Senator Demario.
I will let you know that there are revisions based on exactly what you're talking about, Senator Bell, and so we want to look at those proposed revisions to see if they have the type of impact that you've shown a concern about.
Thank you, Mr. Chairman.
Yep. The next bill posted for hearing is Senator Mack's Bill 710, an act relating to insurance, accident, and sickness insurance policy required health insurers to limit covered persons' out-of-pocket costs for prescription and specialty drugs to no more than $100 per month for a 30-day supply. Senator Mack has contacted myself and Vice Chair that she will be unable to testify as she's involved in another issue. I'm not sure if we have any calls on it either, so we'll leave that to the end after we hear if there is any testimony or for people to review the written testimony. Senate Bill 712 by Senator Goodwin. Many people are familiar with this bill, and it's an important bill to myself as it relates to my codification of the ACA and essential benefits that I'm the sponsor of, as many of you know, the health insurance commissioner previously, 2 years ago, I believe it is now, had a work group that met for, I think we had 14 meetings. Senator Golden was also involved in that work group. And I think it was 14 meetings, and the convening was a large group of stakeholders, including those who were enthusiastic and those who were concerned about the issues around the ACA, reinsurance, and insurance mandate. The issue of annual lifetime limits came up as something that many of us were interested in including in the recommendation that we codify the ACA. Because of the makeup of the stakeholders, that was left out of what could be reached as consensus, and therefore the legislation that came out of that work group included a separate bill around annual and lifetime limits, and many have been interested, and we've heard a lot of testimony around why wasn't this in, and that's my best explanation of why that wasn't in my legislation that's more comprehensive to the ACA. So this legislation is very important to me, and Senator Goodwin saw it important for many reasons that will probably be obvious to many committee members and beyond, and those who are watching. And so I enthusiastically support it, but we do want to wait to hear if there's testimony and to have staff look at if there needs to be any revisions based on, I think there was a House hearing, so we want to look at the House hearing notes on this also. Senator Oyer also called in on unable to present her bill 112, electronic monitoring in nursing and assisted living facilities. I do know that we will be hearing testimony when we get to the call-in on this bill. Senator DePalma already presented on 793. Senator Pearson is in finance, but the bill is very simple, and asked me to explain the simplicity, which you can see in the bill, and that it adds another member to the Rhode Island Board of Examiners in Dentistry. And I'm not gonna, I always get that oral surgeon, adds an oral surgeon. And then the last bill posted for hearing is by Senator Mendes, and it would expand dental coverage to require full coverage for preventative dentistry, endodontics, and implants, and require a prompt pay to for insurers. And it would also require to waive deductibles for the remainder of the pandemic. So if there are no questions on any of the bills that weren't represented by the sponsor, we can move ahead to calls. Senator Mendes.
Surprise, I'm here.
That's great. Go. So I just gave my explanation of your bill. Do you want to give your own explanation?
Do you mind?
Go right ahead.
Thank you, Chairman. I appreciate it. Yeah, I'm particularly excited about this bill, so thank you for that opportunity. Because I do have a history of working in the dental field, and I'm aware of a lot of burdens that are put on small private practices and on patients. Rhode Island has a number of dentists that are in private practice, and there are a lot of issues that are low-hanging fruit that it's easy to address that would that are affecting them and the patients that they care for. This bill seeks to address a few of those issues. The first issue is timely payment to providers. I know that oftentimes, so there's a it's terribly ironic. So providers have a small window in which they can submit a claim to an insurance company. And if they do not do it in that timely manner, for whatever reason, administrative reasons, whatever, they do not get paid. That same courtesy is not extended to providers. So when providers issue a claim to an insurance industry to a dental insurance company to get paid, and the insurance company can take its sweet living time to pay them back and to pay on those claims. They can take 6 months, they can take 9 months, they can take a year. And the time that it takes, the administrative time and the labor time that it takes to follow up on those is costly, and the burden is on the provider. So what this seeks to do is just make it fair. So if there's a time limit on providers to submit claims, then there should be a time limit on insurance industry to pay on a claim. This similar clause is regarding denials. So what often happens is providers are not hearing back whether a claim has been accepted and will be paid on, or whether that claim has been denied. And so if an insurance company is just sitting dormant and quiet on a claim for a very long period of time, a provider can find out a year later that not only is the claim not being paid, but then it's been denied. And they have to go through the appeal process, and which oftentimes requires another x-ray, and that tooth is not always in the same condition that it was a year ago. And it's just really a taxing process. Another portion that this bill seeks to address is the level of exclusion. So dental insurance industries have gone unchecked for a really long time, and they have been able to increase what they exclude and how they exclude what they pay for. Oftentimes, people will get dental insurance and be very excited that they have good dental insurance, only to find out there's a high level of exclusion on pre-existing conditions. If someone had a prior trauma to their mouth, or congenital defects that caused missing teeth, etc., it is not covered. So this seeks to protect those people and have them covered. And the last and probably the most important and timely piece of this legislation is that it does address what we just experienced through COVID-19. So in 2020, the majority of people, a lot of people, did not seek routine dental care. They did not see their dentist. They did not go in for regular checkups. They did not go in as much as they would have. A lot of people put off care, whether it was through fear or through funds, whatever it may be. And there's a really interesting and I think borderline criminal part of dental insurance that is very different than medical insurance. It caps out at the end of the year. If you have not used your benefits, it is gone. For most plans, it is gone. So dental insurance has two features. It has a feature that maxes out. They pay a certain amount in a year, and then that's it. That's the cap. And then it also has, once your benefit year is over, that's you cannot have the funds that are available to you unless you have a rollover clause. What this seeks to do is, it basically states, if we're in a pandemic, your benefits should roll over. So if you did not use your benefits in a pandemic and now it's 2021, you should be able to use those unused benefits. And so the deductible piece is just a part of it, but the biggest part is that a lot of people had their benefits not available to them for various reasons during a pandemic, and I think that's wrong, because the dental insurance companies made a windfall while other people were suffering and not getting the care they needed, and I think that's wrong.
Any questions for Senator Mendes? You brought up an interesting issue. Senator Bell, did you have a question?
I just had a comment, but if the chairman wants to go first, I have no objection to that.
Okay. I was just bringing up the issue that there's a good reason, and to the point Senator Mendes made, that it's not it's why it's defined legally as not insurance. They're defined as plans, so that,
Yeah.
so that it doesn't have the same regulatory oversight as insurance. And part of the advantage that it gives them is some of what you explained about the turnover, which is very different under a pandemic. And not only did people, were they either concerned or unable to go to a dental appointment, but many dental offices were closed. They were forced to be closed until there were some precautions built around it. And so, and I've heard even this week from people who are involved in this issue.
Yep, you're absolutely right, Chairman. And if I may, I often would explain to people that it's more like a reimbursement. It's not insurance because people are confused and think they're insured, and it's just a very low. It's can be more comparable to a coupon than it could be to insurance any day of the week. But yes, I agree.
Yeah. So the other issue related to further action on this bill is that you will notice that we do have a fairly long call list considering the amount of bills we have. It's not that long. We have a lot of bills posted today. I'm a little surprised by how few, not few, there still is some calls to get to, but it seems at least this week, and other committees are getting the same kind of thing, is that we do have a huge amount of written testimony represented by this, which is over 100 pages long. And a good portion of it relates to this bill. So it would be responsible of us on both sides of this bill for us to review what was sent in as written.
Thank you, Chairman, and I'd like to hear back from you about what was in the, who was for the bill and what opposition there was.
Yeah, we can make the written testimony available to you.
Thank you so much.
Yeah. Are there any questions? Senator Bell?
I just wanted to thank Senator Mendes for putting in this legislation. I think it's an incredibly important bill. I think that we have some important regulations around health insurance in our country, and so many of them don't apply to dental insurance. And all of the logic that argues for all these important protections in non-dental health insurance, I don't see why it shouldn't apply to dental insurance. I also wanted to say I did have a chance to review the written testimony and the opposition from America's health insurance plans. So I did not find that particularly compelling. My perception of some of the opposition, at least that we've received in the written testimony so far, is it seemed to be primarily motivated by insurance companies wanting to continue bad practices, and that seemed to be the primary theme of the written testimony. So I was not particularly moved by it, but I'm interested in listening to additional potential testimony.
Thank you, Senator Bell. I think actually you reminded me of one piece of this legislation that it did address is that increasingly we're seeing deductibles applied to preventative care over and over again. Insurance companies are now just attaching a deductible to getting a cleaning or basic x-rays, which is deterring hardworking people to getting the care that they need. So yeah, I agree with you, and thank you for looking into that.
Any other questions for the sponsor from the committee? Well, thank you for showing up, and I'm glad I didn't notice you to the very last minute to get you in under the wire before we went to other calls.
No problem. Saving the best for last. I appreciate it. Bye.
So I do want to go to the calls. And the first, before we get to the calls, the first bill we're going to hear from calling in is on Senate Bill 112. And I wanted to read one of the written testimonies. This is we are still under pandemic conditions in the committee. And that means there's a protocol around how to sign up either to call in or submit written testimonies. And there's 2 different deadlines, and not everybody's familiar with, and why should they be? Why should every citizen who wishes to be heard around legislation be totally up to date on what we're currently doing in committee hearings under the combination of Capitol TV, people calling in, and people submitting written testimony. So we did get somebody who wasn't able to sign up and has health issues with family members, and she desperately wanted to be heard on Senate Bill 112. And so the best I could come up with was to commit to reading her testimony. Because the idea of breaking the protocol would have an impact not only on this committee but on other committees. And so this is the best way I could navigate it, was to commit to this advocate to reading from her testimony on Senate Bill 112. And she represents, or is one of the main founders of the Alliance for Safe Communities. Some of you might have heard from her, Carolyn Medeiros. And so I'm going to read what she submitted in writing as per conversation with her on the phone, because she was very concerned about not being able to call in. So her testimony in favor of Senate Bill 112, Senator Oyer's bill. It's with great hope the Alliance for Safe Communities offers testimony in lieu of Senate Bill 112, finally bringing cameras for residents and nursing and assisted living facilities to reality. In 2013, the Alliance worked together with an investigative reporter, Jim Terracani, covering a plethora of cases from a murder at an assisted living caught on surveillance, a facility shut down for neglect, abuse, death resulting in sexual assaults of a patient, where 5 whistleblower nurses came forward and were terminated from their employ as a result. Several other media, television stations, and journalistic sources covered it that year as it unfolded. Alliance for Safe Communities introduced necessary bipartisan camera legislation that year, as 5 states were successfully moving forward. It was beyond disappointing Rhode Island was not either willing or able to allow the law to come to fruition. Alliance worked with advocating for victims and their families of these tragedies, as well as nurses who were whistleblowers. Alliance testified with all involved. The Alliance worked with national organizations that were involved in moving legislation through their states at the time as well. We have now experienced a COVID crisis, which has exacerbated already concerning conditions in nursing homes. This year, the Alliance highlights one major case which received media coverage and whom we work closely with regarding the victim's family. Mr. George was noted as an at-risk to fall patient. Mr. George experienced 3 concurrent falls. The family was not notified of the incident. It was only after a Zoom call from one daughter that Mr. George's condition was revealed. The daughter had to initiate the request for a rescue transport Mr. George for evaluation at the hospital for review. I enclose one of our 4 requested letters for information regarding the investigation our governor declared and launched by herself and Dr. Scott at a press conference following the release of photos via social media and news outlets. These requests for Mr. George's daughter were never responded to and, in fact, ignored. Senate Bill 112 is a crucial part of improving and providing quality care in our nursing homes and assisted living facilities. At least 10 states have moved forward with passing legislation and 4 more are in progress. It is worth noting that during the COVID crisis, families have come forward to the Alliance for Safe Communities with their concerns, incidents, and inquiries. These families have unanimously supported cameras in these facilities. The Alliance has both photos and video footage from these families as well. Please feel free to ask any questions regarding the collective work of the Alliance for Safe Communities, and we have engaged in regarding the nursing home cameras and for families during the COVID in Rhode Island facilities for our elders. Respectfully and gratefully, Karen Medeiros. So with that, and I'm sure all of you have seen or are now aware that that written testimony is in there, and it was the best way I could navigate for somebody who had an unexpected family emergency to still have their testimony heard other than written. So now we will get to the calls. And the first person who has signed up to testify is James Nyberg. Okay. Mr. Nyberg? Mr. Nyberg? Mr. Nyberg, are you on with the committee? So now we will get to the call. And the first person who has signed up to testify is okay. Mr. Nyberg, are you on the line now? Mr. Nyberg? Mr. Nyberg? We'll go to the next call, which would be Scott Fraser, and try to get back to Mr. Nyberg. Mr. Fraser?
Yes, Mr. Chairman.
You're on with the committee. I believe you're signed up to testify on 112 and maybe one other bill?
That's correct. Would
So
you like me to do both?
You can do both if you prefer, rather than having us try to call you back.
All right, that would be great. Thank you, Mr. Chairman.
Yeah.
Good evening, Mr. Chairman, members of the committee. My name is Scott Fraser. I'm the president and CEO of the Rhode Island Healthcare Association, and we represent 63 of the 79 nursing homes in the state. I'll begin my testimony with S-112, pardon me, and we are opposed to this legislation, and we're opposed to this legislation for a number of reasons. For one, we are opposed for the dignity of our residents. The nature of the care we provide is intensely personal. Nursing home residents typically need assistance with bathing, dressing, and using the bathroom. And even if a resident and their roommate agree to this type of filming, it's an intrusion on each resident's privacy. We're also concerned for the quality of care. Rhode Island is at the top of the charts in many national rankings. Most recent report from the Government Accountability Office, we're #1 in infection control. From the Office of Inspector General, we have the lowest number of inspection deficiencies of any state in the nation. And in 2019, America's Senior Health Report ranked us second in the country in overall quality. Nursing homes in Rhode Island already have dozens of cameras in place in common areas. There really is no need to install additional cameras in private rooms because there is no problem with abuse of residents. It is not a serious problem in this state. We're also concerned about this bill because it would harm the relationships between staff and residents. Families of our residents want our staff to develop relationships with their family members, to be compassionate and spontaneous. This bill would greatly impair personal conversations between nursing home staff and residents. Our staff wouldn't be able to talk with residents about personal matters in a room where they know they're being monitored and recorded. And it's very hard to develop these relationships when you're under 24/7 video surveillance. We're concerned about the potential for hacking. We've all heard about problems with criminals hacking into nursery cameras monitoring young children. No one wants to see a repeat of this with hackers getting into nursing home private rooms. We're concerned about the potential for opting out of camera use. If a roommate refuses to give permission and the other roommate's family wants a camera, one of them will have to be moved. And such a move is very unsettling and traumatic to frail, vulnerable nursing home residents. It's very upsetting. Other concerns, how do you ensure the camera is not aimed in such a way as to film in the hallway? Other residents have a right to privacy and not be filmed by room cameras. If the camera is portable, how do you ensure it's not misused? A resident with dementia could roam the halls with the camera filming any and all that they come in contact with. These are just some of the reasons, but I've stated the major ones that we are opposed to Senate 112. And for all of these reasons, we ask you not to pass this legislation. Regarding Senate 793, the Rhode Island Healthcare Association is testifying in support of this legislation. This is legislation that we have put forth on behalf of our members. In 2012, state law regarding reimbursement of nursing homes was changed. In an attempt to make future reimbursement fair, a Medicaid inflation index was added to the law. That law also, as you heard Senator DePalma state, required a rearray, that is, a reexamination of overall nursing home costs every 3 years. Since that time, the state has never followed the law. The law on rearray has been virtually ignored. This legislation is an attempt to begin the process in order for Medicaid rates to be sufficient for nursing homes to be able to reimburse their employees. A recent study by Clifton Larson Allen shows that Medicaid rates are insufficient and homes are losing more than $28 per Medicaid resident each day. When you multiply a $28 loss by the number of Medicaid resident days, that total loss for 1 year comes to $51 million, a truly staggering figure. Something needs to be done to help our homes, at the very least, break even on this Medicaid program. This bill states that if EOHHS continues to ignore state law, an automatic 3% increase in Medicaid rates would be granted. In addition, as Senator DePalma mentioned, in addition to the rearray, this legislation has a provision that ties increases in the minimum wage to an increase in Medicaid reimbursement. Rhode Island has seen a noticeable increase in the minimum wage in the last number of years, at least 42%. Without a corresponding increase in Medicaid rates, it's virtually impossible for nursing home operators to pay their staff the living wage they deserve. 70% of every Medicaid dollar received by nursing homes goes to wages and benefits. Therefore, it's imperative that Medicaid rates be adjusted upward every time the minimum wage is increased. For these reasons, we support passage of Senate Bill 793. And I thank you for your time and would be willing to take any questions.
Any questions on either one of those bills, Senator Bell?
Thank you so much, Mr. Chairman, and thank you for your testimony, Mr. Frazier, I believe.
Yes.
I was wondering, one of the things in your testimony that caught me was that you suggested that there would be concerns about consent not being given by patients, even when patients have signed consent and have given consent. I was confused about that, and I was wondering if you could elucidate that point a little bit. It seemed to me like once a patient has given consent, that would be consent. What exactly are the consent issues you feel are not fully addressed in the provisions in this proposed legislation?
Yes, Senator, and I'm sorry if I wasn't clear on that. My concern about the consent is if a patient is in a double room, if a resident is in a double room, and he or she gives consent, but their roommate does not, and that would mean that one of the residents would have to be moved to a different room where at least both of the residents have consent for the video camera to be in place. And that's my concern because of the turmoil and the disruption that would cause to the resident having to be moved.
If I may, thank you so much. I had not seen the section that requires that the roommate be moved if they don't sign consent. So I had missed that section. Thank you so much. I'm looking to see if I can find that language now.
Well, and Senator, I'm not sure it's in the section, but if you have a family, if this bill passes and you have a family that is strongly advocating to have a camera in their room for their loved one, and there is consent given by that resident, if there is no consent given by the other resident, then you get a stalemate. And if the family is demanding enough, they would either ask that their loved one be moved to a different room, or they would ask that the resident who's not giving consent be moved. It's a potential for a problem. Again, it may not be in the legislation, but it's certainly a potential that our members see cropping up if this legislation passes.
Okay, thank you so much. That clarifies that. I had thought from your comments that it was in the legislation, and I was unable to locate it in the legislation. It does seem to me somewhat like a thin concern. I'm very glad that the legislation has protections to make sure that the roommate has to consent. And I think that those protections are necessary, and I'm glad they're in the legislation.
And Senator, I would agree that both would have to consent for the camera to be in. That's as you heard, that's not my number one concern, but it is one of the concerns that we'd just like to bring up to your attention. And I thank you.
It isn't part of the bill, so we can review that language as part of our deliberation. I think we have Mr. Nyberg. Which page?
Hello.
Mr. Nyberg, you're on with the committee. You can go right ahead.
All right. Thank you, Chairman Miller. Similar to Mr. Fraser, do you want me to testify on both bills, S112 and S793?
Yes, and before we get to your testimony, I just want to point out for anybody who is looking for that, if you go to page 3, starting at line 25, it talks about shared room and the recommended language around that. So go right ahead.
Yeah. Okay, yeah, thank you. I was going to touch on that, but now I don't have to, so I'll be even briefer. So in regard to S112, I just want to say Leading Age represents nonprofit nursing homes and assisted living residences. And so first, obviously, we appreciate the sponsors of this bill for their interest in protecting the health and safety of our residents. But we are concerned about the bill because of privacy issues and also because it runs counterintuitive to our decades-long effort to implement resident-centered care, ensure resident dignity, and create a home-like environment. And I know I read your testimony from the Alliance for Safe Communities and that COVID raised a lot of concerns and issues about resident safety, and it certainly has been difficult. But I can assure the committee that providers worked hard to ensure the safety of their residents. Currently, they have to follow several established policies and procedures at both the state and federal levels, including reporting any incidents or suspicion of elder abuse or neglect to the health department, police department, and the long-term care ombudsman. Nursing homes and assisted living residences are also regularly visited by the health department, the ombudsman, and others to observe the care being provided to residents and to promote their well-being. So our position to the proposed legislation is both practical, like I said, involving residents' rights, dignity, and privacy, and logistical concerns, and philosophical. On the practical side, we note that most rooms in nursing homes here in Rhode Island at the moment are still semi-private. So if one resident opts out, it'll be almost impossible to respect the privacy and intentions of both residents. And as you mentioned, the logistics of consent and moving a resident when another one objects to the surveillance could be very difficult. The goal for nursing homes and other providers is to keep people as comfortable in their own environment for as long as possible. So lastly, we do have philosophical concerns about this legislation. Nursing homes and other providers have made serious investments in buildings and staff to adopt resident-centered and person-centered care and a home-like environment. We just feel that the installation of video cameras to monitor every move residents would make would disrupt these efforts and add a big brother feeling to our facilities. And lastly, I would just also add that having been in the job for a while and talking to administrators over the years, these video requests are extremely rare. I had one administrator who's been around for a long time who said he's never had a family member request one. So I just want the committee to know that I don't think there's this big issue out there of demand that has been denied by the industry. So with that, I'll turn to S793, and I'll be brief because Mr. Fraser laid things out pretty well. We obviously support this bill, and I echo what Scott Fraser said. Quite honestly, I can't believe we have not had a re-array since 2012 when it's required by law. It seems like every 3 years there's one reason or another, so it's been kind of frustrating. And so the fact that this bill will put some teeth into requiring a re-array will help address that. And also the component about tying the minimum wage to nursing home increases is critical. We have not opposed increases to the minimum wage, but it's also increased dramatically in recent years, 55% from 2012 to 2020, and now we're obviously on a path towards the $15 minimum wage. So when you're a publicly funded provider, like nursing homes are, you can't just pass on the cost to consumers because most of your funding, 2/3 of it, comes from Medicaid in this example. So this bill would help rectify this situation by ensuring that nursing home rates are adjusted by any minimum wage increase and help them address their workforce challenges and keep up with the workforce needs. So thank you for your time, and I'm happy to answer any questions or concerns.
I believe Senator Bell has a question.
Yes, I do. Thank you so much, Chairman, and thank you for your testimony, Mr. Nyberg. I have been reviewing this legislation a little bit more carefully during this hearing, and one of the questions that I had that arose, though I do still support the legislation, is about the penalty section. And in the penalty section, it says that a licensed facility shall be guilty of a misdemeanor for each violation, punishable by a fine of not more than $500. And it says that if you share if you share a video, you're guilty of a misdemeanor. But in the section that refers to sharing a video, it says that you can be civilly liable, but doesn't define what those civil penalties are. So my question is about the implications of applying a criminal penalty to a facility. Now, there's no punishment of incarceration, but could you perhaps help us understand what that would mean to a nursing home to receive a misdemeanor violation as a corporate entity? I'm familiar with criminal penalties typically being applied to individuals, but what is the impact of doing it not as a civil issue, but is a criminal issue without incarceration applied to an entity. What would that mean? What effect would that have? What are the benefits and drawbacks of that particular approach?
Well, I think first of all, nobody wants to be sued or be convicted of a violation. Certainly not nursing homes. They've undergone a terrible experience during COVID in terms of negative depictions, and so to have a lawsuit related to violating some sort of electronic surveillance statute would only further exacerbate the negative perception of them. So I think perception-wise, it would be a problem. I'm not a lawyer either, so I'm not an engineer either, like Sen DePalma. So I don't think I can adequately answer your question. But any threat of a lawsuit to a nursing home is certainly a cause for concern, and I think you raised a good question, and that's another concern related to the bill. I mean, if there's all these other issues associated with consent and residents' rights, that all of a sudden they could be subject to a lawsuit is problematic in my opinion.
Thank you so much. I know it is a somewhat technical legal question about the impact of this, and I did just only notice this now while reading the legislation, but I am somewhat concerned about the possibility of applying criminal sanctions to the entity. And although I think it would, I'm not opposed to having civil liability, I think that the civil liability should be defined clearly. Now, perhaps there's implicit definitions within our civil procedures code, but I do think in general we define civil liability and what those penalties are when we have a statute that clearly indicates there will be civil liability, and leaving those penalties undefined I think is potentially vague and could create some technical issues with the statute.
Right. I appreciate your eagle eye on that issue and share those concerns, and certainly wouldn't want this issue to create further problems for nursing homes or their residents or staff for that matter.
Any other questions for Mr. Nyberg on either bills that he's testifying on? No, thank you for calling in. I'm glad we got your phone line issue solved.
Yeah, thank you very much. I appreciate your time and the time
Oh.
of the committee. Thank you.
Yep.